It is a great pleasure for me to be able to present experience in 3D guided catheterizations from Polish Mothers Memorial Hospital and the team I showed you yesterday. So we started 3D guided catheterizations in 2010. Until now, we've done more than 500 cases, and I would like to briefly show you some of the examples, although it's impossible to show you every application of this modality. We were lucky to participate in all three 3DRA symposium organized by the group from Utrecht in Netherlands, and last year we also contributed to the meeting in Columbus. As you could see, or could have seen today or yesterday on most of the presentations, 2D angiography is the gold standard to make the diagnosis in cath lab or to conduct intervention. And many doctors advocate actually that the BIPLANE 2D angiography is the gold standard. So let me show you an example of that gold standard. Here you can see angiography, contrast injection to the right ventricle, AP and lateral projection. So you can already see that there are some issues in it with the dilated outflow tract and stenotic pulmonary arteries or hypoplastic pulmonary arteries. So in order to gain more information, we advance catheter to the MPA. And again, here we gain more information about pulmonary arteries. However, the origin of the left pulmonary artery is not quite well seen, so probably we need to do another injection according to the gold standard. And here you can see severely hypoplastic left pulmonary artery in 2 projections. So we are ready now to take measurements and to decide what type of device. So here we go with the long sheath, and we position the stent. After uncovering the stent, 1 more contrast injection, and finally we are happy with the position of the stent. So inflate the stent. I spare you in stent inflation. After inflation and stent redilation, we do check angiography to see the position. Well, you may see that there is some contrast extravasation. However, we have improved flow to the left pulmonary artery. So that is a safe way to have a good result. However, it is time, contrast, and radiation consuming. So perhaps there is a better way to guide that kind of intervention. So as you can imagine from the topic of my presentation, I'll show you now an example of rotational angiography to guide pulmonary artery intervention. This is a patient with severely stenotic proximal left pulmonary artery. We perform here rotational angiography without rapid pacing, but with apnea, single site injection, 0.5 milliliter per kilogram per second, and so the run is 4 seconds, so 2 milliliters per run. And from rotational angiography, in less than 30 seconds, we have the 3D volume available, and we have to do some post-processing on that 3D volume in order to have the lesion well exposed. And here we focus only on the proximal left pulmonary artery with some cutting because we do it during intervention and the patient is on the table, so we don't want to spend too much time on post-processing. Therefore, we don't pay too much attention to have beautiful images. We just focus on the lesion. And measurements, we tend to take measurements on rotational angiography images. The 3D reconstructed images, mostly they are volume rendered, so as you know, you can sometimes have less accurate measurements. It depends on window leveling. So measurements into the images from rotational angiography. And finally, we go to 3D roadmap and to guidance of the intervention. And here we go with the long sheath, and you can see that despite the fact that we have their well, relatively stiff wire and the long sheath, the alignment of the 3D volume and the proximal left pulmonary artery is quite accurate. And then we go with the intervention. Here, perhaps you can see that the stent is too distally placed. We go back with the stent, it's more proximally placed, then we post-dilate the stent, and we do final assessment, so rotational angiography again, no pacing, so you can see that there is some washout of contrast, but despite that, we still can have very nice 3D reconstruction with improved proximal diameter of the pulmonary artery. So there is another way to perform that intervention. Our vast experiences and biggest experiences in single ventricle patients. And if you are to start applying 3D array, I would suggest you do it in that patient population. And there are certain reasons for that. Obviously, these patients come very often to cath lab. They have some residual lesions, and we want to spare radiation and contrast, especially in those smaller patients. On the other hand, there are some positive aspects in these patients. So usually there is slow blood flow and a limited washout of contrast, which improves quality of our 3D reconstructions. And vessels are relatively big and with small systolic diastolic variability in dimensions, that all adds to better quality of 3D reconstructions. Okay, so yesterday I mentioned we typically go through the Norwood-Glenn-Fontan sequence, and we've used 3D array in almost all, except we did use 3D array for restrictive intra-atrial septum, but I'll just show you some of the examples. Yesterday I showed you PDA stenting, so I'm not going back to that, but what I want to emphasize that in that paper we were able to show that 3D guided ductal stenting comes with lower radiation and lower and similar contrast exposure to 2D angiography. If we go a step further, that's the last case I presented yesterday. So if we have pre-catheter CT or MRI, we can use it to guide our intervention. And here I want to focus on the benefits of that. So if we compare contrast administration usage, for example, so 5 milliliters versus 24 milliliters for ductal stenting in similar in size patient. Fluoroscopy time in these two cases was shorter fluoroscopy time in CT-guided intervention, and radiation dose was also lower. We don't have bigger number of patients for the moment, but we would like to show that improvement also on a larger group of patients. So stenotic aortic arch, it's not that common in our population. However, we do these studies without rapid pacing, so you can see there is some contrast washout. However, with a contrast amount similar to two regular standard 2D angiographies, we can have many more rotational angiographic images, and then we have 3D reconstruction. We overlay it to conduct the intervention. In this case, it was balloon dilation. Of course, if we can, we want to avoid stent implantation. Now, let me take you to problems with pulmonary arteries, because that's, in our experience, is probably the most common lesion we need to treat in those patients. And if you look at that rotational angiography, and if you focus on the images, you can see that perhaps the coronal or diameter of that pulmonary artery is not that bad. However, if you look at the 3D reconstruction, you will find out that when we look from the top or from the bottom of the patient, we can actually find out that there is a significant narrowing of that vessel. Actually, that vessel curves around the neo-aorta. So at the beginning, we used 3D array to understand anatomy better, and we gave undiluted contrast for rotational angiography. As you can see there, it gives you also good 3D reconstruction, but also this patient had BT shunt, and in order to limit contrast washout, we occluded temporarily BT shunt. So another way to have better images is to try to temporarily occlude additional shunts. Okay, so from imaging, we went to using that information in interventions. And here you can see a patient after Glenn, and I would like to show you, okay, hopefully that will run. Okay, that doesn't run. So the idea on that slide was to show you regular 2D angiography versus rotational angiography, which is here. And again, we can see that there's a problem with pulmonary artery, predominantly the left, but also the proximal right pulmonary artery. And not only we have many 2D angiographic images, we also have 3D reconstruction. In the next stage, we use 3D reconstructed images to select the best projection. Yet we took the measurements on 2D angiography, and we used 2D imaging to guide stent implantation and to assess the final outcome after stent implantation. Okay, but later we started using also that 3D reconstruction to guide the intervention. And this is example of a patient after hybrid treatment with even here the critically stenosed left pulmonary artery, and there is a remnant of the stent in the ductal area. So we use that 3D reconstruction to overlay it on 2D images and to guide our intervention. Here you can see we're introducing stent, and hopefully on the next slide you'll be able to see or not. To see the outcome of that intervention. Unfortunately, my slides are not running. So from rotational angiography to have more information, we went through, we use it to guide the intervention and to assess final outcome. And in those patients after Glenn operation, in some cases we see that when we introduce stiff wires and then long sheets, the misalignment sometimes is quite significant. Therefore, we also had to adjust our techniques. And you can see that initially we here go with the coronary wire to perform balloon dilation. Later we have a stiffer wire. In this case, there is not that much mismatch, but sometimes we decide to use coronary wire to introduce stents. Although I know it's not a common way to do it, however, that may lead to less misalignment. Yep. Next slide. And next. Okay, so here we go with a stent, and here we have 3D array after the intervention. Thank you. Okay, so, and here you can see the outcome. So we have more contrast flowing now to the left lung. Hopefully that will sustain for a longer time, and you can see the image before and after. Okay, so now heading to patients after TCPC. Here the typical projections, AP and lateral. So I guess it's clear for everyone that this patient has got significant extracardiac conduit stenosis. If we look at rotational angiography, one more thing comes to our attention. Not only the stenosis that I showed you before, but one more, and it's best seen in the LAO 35. So again, frame selection is important. Here we have 3D reconstruction. We can use it here. In that case, we decided to take some measurements, and we stented that first narrowing and ballooned the other lesion. Okay. However, in patients after Fontan, the problem is sometimes that if we inject contrast to the tunnel, we don't know much about the situation in the SVC or in the innominate vein, so we have to perform additional injections. And here, so we decided, let's try to do rotational angiography. So we did one with the catheter in the innominate vein, second in the extracardiac tunnel, but that is also obviously time-consuming and contrast-consuming. Therefore, we went a step further, and we decided to perform multi-site injection. So on the right image, you can see injection to 3 sites. There is a pigtail catheter in an innominate we inject contrast through the long sheath to the extracardiac tunnel, and there is also a short line placed in the neck vein on the right side. And we compared results in 62 patients with 100 rotational angiographies. We divided patients into 3 groups: those who had 1 single-site RA rotational angiography, or 2 serial single-site rotational angiographies, and finally the most recent group with simultaneous multi-site injection. And baseline characteristics were not different, but what was different that the patients in the group with the multi-site contrast injections had lowest number of additional angiographies. That was significant, and as far as contrast usage is that they had the lowest contrast exposure. Similarly, the radiation exposure in that group was also lower, and total study time was also improved with multi-site contrast injection. Okay, so let's skip this one. And in conclusions regarding 3D array, I would like to say that rotational angiography clarifies the anatomy. 3D reconstruction gives us unlimited views. The roadmap can facilitate catheterizations, and the final results may be more predictable. And let me take you now to the most recent work that we do, and I briefly mentioned that at the beginning. So we started using VESSELNAVIGATOR. So we apply CT or MRI images for guidance of catheter interventions. This is our first case, aortic coarctation. It was presented last year with a group from Berlin. They have the prototype of that fusion system, and they also use MRI image. The important improvement is that with pre-catheter imaging, we can do the segmentation and planning of the procedure before the patient is brought to the lab. So we start with registration, and that saves us time, which is very important. And to finish, I would like to show you an example of, we compared 2D guidance, 3D RA, and VESSELNAVIGATOR guidance for melody valve implantation. And if you look at the last bar at the right, shows VESSELNAVIGATOR, so fusion imaging, and we were able to show that fusion imaging comes with reduction in contrast, in radiation exposure, and in study time, especially when compared with 2D guidance, but also when compared to 3D RA. And last year we started cooperation with Senkho and 3 other groups, and hopefully in a short time we'll have results of our multi-center experience with that novel fusion software. So when you change the way you look at things, sometimes the things you look at change. And thank you very much for those 4 days here in Incheon. That was a great experience for me, and I hope you to come here back.